Karen Payne, NHS Yorkshire and Humber Public Health Workforce Lead. As the commissioner and key developer, it came about following NICE guidance, the behaviour change guidance of 2007.
Yeah.
And that put forward a challenge around coming up with basic standards, standardised standards that would help us maybe implement guidance, along with the challenge of equipping staff to be able to do behaviour change at the front line. So we took that challenge along with the Darcy Staying Healthy challenge of how to really embed staying healthy and the principles of public health and prevention and lifestyle behaviour change into everyday work and the practice of our workforces. The thoughts behind the framework were very much a standardised, basic, simple, one-page architecture that could enable change and transformation in both workforce and services to enable behaviour change to be at the front line and part of staff's everyday practice, become a norm really. I think if we were to look back 3 years from where we've come from to where we are, we've made quite significant inroads, especially across Yorkshire and Humber, and some of the others will share their experiences in other Vox Pops. But certainly as the regional response, we've seen seismic change and uptake of MEC both in Yorkshire and Humber and far wider. The fact that commissioners can use it, providers can use it as a unique selling point, you know, it can really be about embedding it in their workforce as an everyday practice. You know, commissioners desire it because it's evidence-based practice. And what we really wanted to do is bring together that service and workforce architecture so that, you know, it wasn't just about training our staff to do things differently, it was about a culture change. It was about, if you embed the framework within your commissioning, within what the service you provide, you're going to enable a change and a culture change, because by default, by investing in your workforce to do behaviour change in their everyday practice to work to the front line, at the front line with clients, patients, families, communities, you're going to get them taking that home using the asset theory to become an asset of the community, because they have the skills to undertake behaviour change in their own family, as peers, as friends, and it goes far wider than just their everyday practice. So we you know, the aspirations were using that asset theory. And that was also in NICE guidance about using that within behaviour change and using it when you develop things. So we have seen, I think, a social change, and the fact that, you know, Make Every Contact Count and the framework have been picked up and embedded in a variety of services, from police to probation, as well as the NHS. Local authority get it quite easily because it fits their principles and way of thinking. Yeah. So actually, to actually become active in behaviour change, the framework enables the competence and the confidence so that can happen. So that actually we do begin to get that. But the principle behind it is not just about training, it's about embedding that. So if people move on, you're going to train the workforce the same. You're going to build architectures and, you know, support mechanisms like supervision or new services, because behaviour change is identifying further need and it's evolving and changing as we go on. I think the work of leads across health and into local authority is quite exciting. That's led by Candy Rallen and some others in the Leeds team. And that's very much about commissioning it, beginning to commission it within their commissioning contracts, but also working on the training. And, you know, what Candy would say is she's seen, you know, the training provision disappear. You know, they're signed up to it. You know, a year's provision's already gone. So there's a real need out there in the workforce for it. That's along with seeing you know, providers really coming to Making Every Contact Count as if it's quite infectious, as if it's easy to implement, and it's, you know, they're seeing a change. GPs get it, others are getting it, and it's enabling, you know, everybody to doing something around behaviour change, whether it's level 1, brief advice and signposting, right through to level 3, where it's much more programmes of activity that support behaviour change. And, you know, by disaggregating those functions, people can see how they can work with it and how they can actually play a part in it. And that's making it easier in Leeds for that to actually happen. And I think the other one there's two more. Okay. One would be Hull and the active work they've done in their acute trusts, and how they would argue that they've seen a cultural change where it's actually bringing more and more people to the agenda, because they've started in one ward and then it's just bred from there. Yeah. And then the other would be somewhere like Rotherham with Sally Jenks, who's taken it into pharmacy, into leisure, into so many different places that, you know, it's just again breeding a culture change just as much as actually she's beginning to see measurable outcomes. The principles we came from at the beginning were that it had to be more than just training, it had to be change of workforce and service to deliver behaviour change, but also picking up on public health evidence base. It has to be sustainable and measurable. So we wanted to be able to measure different services provided in our level 3, so behaviour change in a managed programme like obesity, across different patches, across different workforces delivering it. So the Making Every Contact Count assessment tool was very much around a self-assessment tool that could be used to look at a variety of measures. So it isn't just about how confident you are, it's also about how it's been embedded. So the assessment tool covers your personal development, recognising that you've got a learning process and it's a lifelong learning process. That there's an issue around understanding the wider and social determinants of health. So the principles we've always incorporated is like the Marmot principles, that if you don't come from where the individual is, you're missing out on an opportunity for actually really getting to the crux of what that individual needs to support them on their behaviour change. It covers organisational preparedness. We know from the pedagogy research and education that many students can go on training but return back to their organisation, and because procedures, the way things have always been done, actually hamper the ability for that person to actually enact this new training. We knew we had to consider all the organisational preparedness elements, making sure it's part of the culture, making sure it's part of OD, organisational development. So it takes on board that. The assessment tool considers confidence, which is a unique opportunity to really look at if somebody's feeling confident in actually undertaking behaviour change. Because there are elements of it that are challenging. You know, it's about a relationship with somebody, it's about a set of communication skills, it's really about having a quality intervention, and there's got to be an element of, is that person feeling confident? And there's a measure of that in the assessment tool. And along with that, it measures their skill at the different levels. Do they feel skilled to be fit for purpose to actually begin and move on a journey of lifelong learning around delivering behaviour change? So the assessment tool is an exciting pull together of a variety of components that is quite unique in its approach, just as much as it would measure how people believe and its self-assessment. So it is about, it does have barriers around any self-assessment, but it begins to measure the different dimensions of delivery, so from confidence to competence, just as much as valuing organisational preparedness, does the organisation support them in this new way of practice? You know, do they understand the wider determinants and how they will impact on somebody in their behaviour change? When we started out, we were very keen to work on the evidence base, because we felt it was very important, particularly as we work in a public health directorate, that, you know, evidence base will make a good strong case but also inform the future and transformation. So we did take an evidence-based approach. At the moment we're working with NICE and Manchester Business School, along with Sheffield Hallam, on an evaluation of making every contact count in practice,
Right.
particularly at level 1, which is something that hasn't had a lot of research about it,
Yeah.
brief advice and signposting.
Yeah.
And the intention is to look at further evaluation of MEC and take that wider than just Yorkshire and Humber, which we did actually in this evaluation. And the outputs of that are very much that it has a viral effect. That if you use these principles, understanding the organisation, understanding there's an element of confidence and competence, and understanding the wider determinants and the evidence base behind it, it can really make a massive case as to why the workforce would want to do it, and then how supporting them with the learning objectives and the ability to do that is meaning that the interaction with patients is changing. We've always been committed to understanding the evidence, but also contributing even more to the evidence base behind doing things differently. And the economic case was about, is there a value in terms of the monetary, finance, resource expenditure that needs to be taken into account around making every contact count.
Yeah.
The outcome being is that, you know, the training will cost,
Yes.
but the return on investment
Yes.
and the cost effectiveness of doing MEC outweighs that. So there's a model in there that can be used.
Yeah.
And we do need to do more
Of course.
work on the economic case. It's something that will continue and could be part of the evaluation that we do with NICE in the future. Making every contact count can be embedded in really good practice that's already there. Just as much it can be part of new services and new opportunities. It isn't about a MEC service at all. It's about using our workforce to deliver making every contact count, wherever, with whomever it can, and using every opportunity to make that quality interaction benefit behaviour change. Our workforce are already doing a fantastic job. They're really busy. What we didn't want to do was ask them to do something that was difficult. So it was very much about using that time that they have with patients, or finding a little bit of extra time to have those quality interactions, rather than having to go to a new service, making every contact count service, that the patient has to find the initiative to go to. You know, they're already there. We have smoking cessation, we have obesity clinics, you know, we have pharmacies who offer healthy living pharmacies as an opportunity. So there's already services there. This is about the workforce feeling confident and competent to actually do behaviour change at every opportunity that arises. So it becomes a norm and part and integrated into services across health, in acute, primary care, tertiary care, wherever that might be, just as much as in police, fire and other services. On reflection, I probably never imagined it would be where we are today in 3 years. Where would I like it to be in another year? To have built more evidence base, to have a cost effectiveness argument, to have some return on investment, to really demonstrate that our workforce, which we spend 60-70% of our resources on already, are actually valued in delivering behaviour change. And actually that means that the training is part of mandatory training, that it's part of everyday practice. So actually, where I thought I would have wanted to be, I think we already are there. It's really about putting more evidence and more literature out in the public domain and measuring it across different services and geographies, north, south, different countries, to really see if this approach, this model and this systematic but simple function-based approach can make a difference in public health and behaviour change.